So today, as Sir has mentioned, we have an important topic that is about kidney transplantation in the elderly recipients with a high immunological risk. Um, as you all know, there's a growing proportion of elderly patients who are reaching end-stage renal disease to the tune of more than 60% in patients of more than 60 years. And unfortunately, more than 65 years, only less than 14% of patients get transplanted. This is usually because of a decreased perception of utility in transplant these patients by the treating physician, as well as sometimes the patient himself consider the transplant may not be worthwhile. And there are few concerns as well as challenges. The major concerns being the decreased life expectancy in these subgroup of patients, the heightened risk of infections, the risk of malignancies, cardiovascular mortality, as well as the problem with the immunosuppression, how to give the injection immunosuppression, and the long-term graft as well as patient survival in this group of patients. So for the next few minutes, I will be tackling on these aspects. So I'll be talking about the kidney transplant in the elderly recipients, what characteristics make them different from the younger population regarding the immunological characteristics as well as the non-immunological characteristics, the immunosuppressive therapy which may be useful, and the tacrolimus exposure in the original as well as generic population and outcomes in the elderly population. So regarding the definition of elderly, it's variable. So earlier studies were like they put it around more than 60 years. Now we know 60 is no longer young, more than 65, 70, 75 years people are getting transplanted. So currently most of studies is more than 65 years is what they define as elderly. So what are characteristics of elderly patients? So what they make them difference is there is a difference in the immunological make. That is, with aging, there is a waning of immunity, both the innate as well as the adaptive immunity. If you look at the innate immunity, there is a decrease in number as well as functionality of the various cells that contribute to innate immunity. The macrophages, there is a decrease in the macrophage phagocytosis, there is a decrease in the necessary numbers, decrease in the receptor expression as well as functionality, and neutrophils, there is a decrease in neutrophils as well as there is a neutrophil chemotactic activity tends to come down. There's an age, the antibody to cytotoxicity of the natural killer cells and the production of pro-inflammatory cytokines tend to come down, and the co-stimulatory effects also is down. So there is a waning of immunity with aging. Along with that, the adaptive immune system also undergoes a change. The adaptive immune system mainly constituted by the T and B cells, which are the major drivers of the cell-mediated as well as the antibody-mediated rejection. So what you can see that as you age, there is an involution of the thymus which happens, as a result of which there is a decrease in the naive T cells, and there is a proportion of the memory T cells tends to increase, and the decreased function of the B cells also. There's a blunted response, and there is a decreased antibody production. The CD4 T cells can dampen co-stimulation, decreased production of interleukin 2, and the T cell repertoire also tends to change with decreased diversity, and there is decreased lymphoid precursors. So overall, what it translates is that there is a decreased risk of the decreased risk of rejection, but at the heightened risk of infections, which might happen in these subgroup of patients. So just recapitulating, there is a decrease in the naive T cells, decrease in T cell receptor diversity, decrease in interleukin 2 production. So there's a progressive atrophy of the thymus, and this may result in decreased immunity with age. So overall, there is alteration differentiation of the hematopoietic stem cells, and the mechanisms of immune dysfunction are many. One is the aging, which is a chronic low-grade inflammation which occurs with aging, and sometimes this persistent low-grade inflammation can contribute to the comorbidities like cardiovascular disease and diabetes. And there is age-related increase in the adipose tissue macrophages, which might produce these inflammatory mediators as well as a pro-inflammatory memory T cells. So that is about the immune aspect. Now again, the non-immune aspect, something which we have to keep in mind is frailty. In age alone is not a contraindication to transplant. There's no upper limit of age as such. It's the physiological age which is important, as well as the most important thing is the frailty or the associated comorbidities, which might put the patient at increased risk of mortality post-transplant. So the frailty is clinically defined as a recognized state of vulnerability due to organ so age-associated decline in this organ function, which might put the patient at increased risk of coping with a stressful situation. So this might be contributed by the comorbid conditions, malnutrition, surgical stresses. And how will you assess frailty? So there is a few ways you can assess it. One is the weight loss. Other is the weakness, which can be assisted with a low grip strength, and then the low level of physical activity, the walking speed, exhaustion, weight loss. These are the various ways you can assess the frailty. There are various scales available to assess the frailty. So the frailty correlates with cognitive impairment, sarcopenia, multiple comorbidities, and in it those patients with are frail elderly people have got increased risk of CKD progression, increased falls, fractures, hospitalization, and poor quality of life. So this is important because those who are frail, they need to be optimized before you proceed with transplant. This may be with the help of improved physical activity, nutritional improvement, psychosocial support, as well as respiratory training. So that's about frailty. Now, the next important question is the immunosuppression. That is a challenging question. How do you immunosuppress these kidney transplant patients? At the heightened immunosuppression can put them at risk of infections. So as already said, like if you look at the alloreactive T cells after kidney transplantation, in the initial first year, where these cells are most active, the risk of rejection is also maximal. Now, these alloreactive out of the total pool of T cells, around 5 to 10 may be the alloreactive T cells, and all T alloreactive T cells may not be reactive as such. The top right ones, they are the ones which produce cytokines, and these undergo activation-induced cell death. And by around 1 to 5 years, the total number of alloreactive cells tends to come down, along with those which are more active. By more than 5 years, these alloreactive T cells are mostly the low risk alloreactive T cells. So the risk of the cell rejections tends to come down. So at this point, actually, you can bring down your immunosuppression. And the risk of cell-mediated and antibody-mediated rejection, if you look at that, the risk is maximal for cell-mediated in the initial few weeks to months, and then it comes down as the alloreactive T cells tends to deplete, and then the risk of antibody-mediated rejection is also higher during the initial period. But there is a low-level DSA which can happen because of whether because of reduced immunosuppression, they can de novo DSA, which can lead to antibody-mediated rejection. So you may not be able to take off your immunosuppression completely, but you can bring it down sufficiently. So again, something which we need to understand is the pharmacokinetic changes and pharmacodynamic changes which happen regarding immunosuppression in the elderly population. So there is a difference in the absorption, the distribution, as well as metabolism and excretion of various drugs in elderly population because of the decreased GI motility, the decreased gastric emptying, the gastric pH tends to change, and as you age, your body mass comes down with the decreased proportion of water. There is a relative increase in body fat, as a result of which the volume of distribution of these lipophilic drugs tend to increase, and the P-glycoprotein activity also tends to be variable, and there is a decreased hepatic as well as renal first pass metabolism and decreased renal excretion. So all these tends to be changed in elderly. So there are few studies which I looked into the various immunosuppressive regimens in the kidney transplant patients. For regarding the induction immunosuppression, the initial one study compared between the various induction agents, thymoglobulin, barzoliximab, and the alemtuzumab. So they found that alemtuzumab was associated with worsened graft as well as patient survival. And those patients with high risk, the recipient with a high risk donor, the thymoglobulin, rapid thymoglobulin may be preferable, and also possible with those with a low risk with a high risk donor. And regarding the dose of ATG, again, some of the studies have shown that a low dose of thymoglobin may be preferable in the elderly population with high risk because of the lessened high dose with heightened risk of infection. So there are other studies also showed that low dose ATG is safe and effective in the recipients. So low dose ATG for patients who are high risk, and the non-depleting agents for those at reduced or standard risk. So regarding the maintenance immunosuppression, there have been various studies. One which looked at the CNI free approach. This calcineurin inhibitors in the long term, this may be associated with the CNI nephrotoxicity, which may be more in patients. The chronic allographic dysfunction is quite more prevalent in the elderly transplant. So there's a CNI free approach, but the study by Arbogast et al. They found that CNI free regimen is associated with heightened risk of acute rejection. So that is not to be followed. Then the delayed CNI introduction, where they introduced CNI delayed, but this did not provide significant advantage according to the study. And then there are studies which looked at the minimization of CNI dose with the lower CNI dose. So reduction immunosuppression was associated with improved patient as well as graft survival, and the attack trough levels were kept slightly lower than in the younger cohort. And there are other studies which are looked into the use of mTOR inhibitors with the minimization of CNI. So this study, everolimus-based free CNI protocols, which they found that they were not quite superior when compared to CNI-based protocol in old to old transplantation. Again, everolimus TAC regimen did not show much advantage. And there are studies which have looked into the long-acting preparation along with immediate release tacrolimus. They found that the efficacy and the safety was comparable when compared to the immediate release tacrolimus. Now, studies also looked at a comparison between whether MMF, antimetabolite MMF, as well as azathioprine. Now, MMF is antimetabolite which might be at increased risk of infection when compared to azathioprine. But they found that MMF was superior to azathioprine because it was associated better patient survival, graft survival, and lower risk of rejections. So the take home is like you can the tacrolimus trough level, the dose maybe a lower CNI dosage may be preferable, and MMF may be preferable over azathioprine. And everolimus usually doesn't show any much advantage over the tacrolimus. Now, regarding the lowering the maintenance immunosuppression kidney transplant recipient, the most frequent cause of allograft loss in the long term is chronic antibody-mediated rejection. But in elderly patients, death with functioning graft is the major cause of graft loss when compared to the chronic antibody-mediated rejection. And the risk of DSA formation as well as ABMR tends to plateau after 10 years of transplant. So you have to balance between that. So you can think of reducing the intensity of immunosuppression as years pass by. And but those with standard immunological risk, there has been a few one study where they looked into tacrolimus monotherapy, especially 1 year after transplant, where they found that the risk of rejections as well as the grafts and patient survival was not significantly affected. But that is those with more than less than 4 mismatch and without any high risk. Now, regarding the personalized immunosuppression, so that is what has to be practiced in elderly trans. No, the elderly trans patients may be different, and the immunosuppression may need to be personalized according to the comorbidities, the risk of infections, as well as the patient profile. So regarding the pharmacokinetics, as already said, there is a difference in absorption, distribution, metabolism, the declining muscle mass, and the variable cytochrome P450 activity. So for CNI, a lower dose of tacrolimus is effective and safer. And regarding the pharmacokinetic of mycophenolate acid, it is not significantly affected by the physiological changes in the elderly. And in general, renal function deteriorates with age, and drugs which are renal excreted should be reduced in elderly patients. And the pharmacodynamics also tends to be changed with as you age, and with regard to efficacy and toxicity. And pharmacodynamics of mycophenolic acid is not affected by physiological changes in elderly. The IMPDH activity is not different between the young and elderly age groups. Regarding the pharmacodynamics of CNI, there is limited data. And there are various other factors which might affect the pharmacodynamics, which includes the comorbidities, the age-related changes in the T cell differentiation, and the use of other co-medications. again, you need to assess the comorbidities as a frailty. As already said, frailty is an important risk factor for mortality for poor outcome after kidney transplantation. And this is associated with an 1.94 increased risk of delayed graft function. And you may need to have, you have to identify this frailty at an early stage, and then with the help of frailty scales, and then optimize the patient prior to the transplant. So, a more balanced decision can be made regarding the kidney transplant, such as by optimizing the patient as well as assessing the frailty at an early stage. Now, let us look into the graft survival in elderly kidney transplant patients. So the graft survival in the elderly patients at 1 year is 84%, which is lower than the younger patients. But with high risk patients, it tends to come down to 58%. So, but it is better than the patient being on the dialysis at any point. So the overall survival may be lesser than when compared to the younger cohort, but it is better than the patient being on the dialysis. And this is the effect of Charlson Comorbidity Index, which is a 19 parameters. There's a scoring. So those with significant comorbidities, they tend to have a worsened graft as well as patient survival. Now let us look into the immunosuppressive treatment in elderly recipients. One is the problems. One is risk of acute rejection, and other is death by infection. So you have to balance and optimize the immunosuppression accordingly. For the patients with high risk elderly kidney transplant recipients, you may need to have anti-thymocyte global induction therapy. And those with low risk kidney transplant recipients, it is better to avoid depleting antibodies and to rapidly taper and discontinue steroids. But discontinue steroids may not be possible. Usually, you can reduce the dose of steroids to the minimum as early as possible, and you may aim for a lower CNI targets 6 months down the line. The trough levels keeping around 4 to 6. And kidney transplant in older patients with high cardiovascular risk. Again, though the elderly patients have got heightened risk of cardiovascular mortality, and those with cardiovascular risk have got decreased 10-year patient as well as graft survival. Again, with age, there is increased risk of infection as well as cardiovascular mortality. But patients who are waitlisted tend to have more risk of cardiovascular infection mortality than the patients who are on getting transplanted. So next is let us look in the difference in the tacrolimus exposure between the Prograf and generic tacrolimus in elderly patients. So generic tacrolimus, they found that there was a increased higher interpatient variability for both area under the curve as well as Cmax versus Prograf. And this was not found to be bioequivalent to the original formulation in elderly renal transplant recipients. Though the trough levels were similar, there was significantly higher systemic exposure of tacrolimus in patients who were on the generic when compared to the Prograf. And there is as well intra-individual pharmacokinetic variability associated with tacrolimus increase in elderly population, and aging is associated with decreased immune responsiveness, and elderly liver and kidney transplant are more likely to develop new onset diabetes also than younger patients, and there is increased risk of infections as well as cardiovascular mortality. And the problem is that the intensity as well as the frequency of rejections are less. But if you have a rejection, it may be more devastating and can have long-term effects. So regarding the incidence of NODAT, NODAT incidence increased in elderly population when compared to Prograf. The generics had incidence of around 21%. This was noted in the study. And again, when we convert from Prograf to generic tacrolimus, it was found there was a significant increase in the serum creatinine. This was a study of 41 stable Prograf receiving kidney transplant, and there was a transition had significantly increased. There was a slight increase in creatinine once they were transferred to the generic formulation. So what are the factors you should finally consider in a high risk elderly? So age alone is not the deciding factor. The associated comorbidities, the risk of infections, the assessment of the frailty of the patient has to be accounted. So a thorough evaluation. So for you have to look for the surgical as well as vascular suitability of the patient, and the thorough screening for infections. Pre-transplant screening is very essential. You have to screen for all the infections, a thorough screening for malignancies in the colonoscopy for more than 60 years, mammography more than 40 years, and electrophoresis in patients more than 60 years, and thorough evaluation and imaging may be required to rule out these in occult infections or malignancies. And then you have to balance between rejection as well as the immunosuppression is the other thing. The immunosuppression has to be tailored to optimal level to prevent rejection as well as the risk of infections to be minimized. So summarizing, aging causes an increased susceptibility to immunosuppressive side effects, particularly cardiovascular disease, infection, and malignancies. And immunosuppression elderly recipients, there is no guideline recommendation. Most of them are from the retrospective as well as observational studies. So for high risk patients, you can opt for a thymoglobulin, but low risk, you should go for a non-depleting non-depleting induction agent. And the recommendation is interleukin 2 receptor agonists or low dose ATG, and maintenance immunosuppression with a CNI and with lower dose of CNI. And reduction of overall immunosuppression can reduce the risk of infection in this subgroup of population. So just going through our data also, we have transplanted approximately 77 cases in the last from 10 years, and the males were predominant, around 66 males with 11 females, and the mean age was around 60, and the highest age was 75 years. And this was mostly, we had around 65, 41 patients who were between 65 to 69, and 14 more than 470 years. And this was the most common etiology was diabetic kidney disease. And again, most of the patients have comorbidities, diabetes and hypertension becoming major comorbidity, and coronary artery disease was seen in around 45 patients, and few of them had undergone interventions, and few patients had prior malignancies. And this biopsy-proven acute rejection was only total of 8 cases, which is 10.3%. And the most common biopsy finding was a rejection, and then there are a few cases of CNI toxicity and 6 cases of ATN. And etiology, the delay graft function around 15%. And the induction agent which predominantly we use was Similect in most of our patients, except few high-risk patients we have used ATG and Graflon. And we had a mortality of around 9 out of these 77, which is around 12%, close to 12. And sepsis was the commonest cause, with ACS accounting for 2 cases. And there was a delayed anastomotic dehiscence in one patient with massive pedigraft hematoma. We lost the patient. And surgical complications, mostly lymphocyte lymphoria, wound infections, and wound dehiscence were noted. And among the infections, the commonest was the urinary tract infections, around 15. And there are 2 cases of CME and 2 cases of BKV infections. And NODAT was around 9% in our study. We had 4 cases of post-transplant malignancies, CA stomach, CA lung, prostate, and multiple myeloma. And regarding the sensitive, we had 6 cases which were sensitized, variable flow cross match as well DSA positivity. A few of all the patients, one of them died of infection. The rest of them are doing well. The induction age was Similect, and a few of them underwent plasmapheresis. And the total case of graft loss around 12%, and 7 were due to death with functioning graft. So overall graft survival, if you look, it's around 87%, with death censored graft survival coming to around 97%. So so between this age group also, in some the overall survival is better, but though with advanced age, there was increased mortality. So the graft survival was around 94 at 1 year and around 87 at 3 years, and the patient survival was also 94 to 87 at 3 years, and rejection was around 11%. And urine tract infection was the commonest infection, and sepsis was the commonest cause of death. So take-home was, in general, elderly transplant benefit from transplantation while gaining an increase in life expectancy as well as better quality of life. There's no upper age limit. The physiological age is more important. So you have to carefully assess the risk and benefits of transplantation, and case-by-case individualization is required. And appropriate screening for cardiovascular events and malignancies, and induction therapy with Similac may be preferred over ETG. Thank you.